Okay. So, oh, it's already open. Derp. Okay, so we left off here, right? We were talking about the lower parts of the brain and its autonomic functions, and we left off talking about the medulla, and some of it's review from chapter 1, and some of it's new. Okay, so we were here, correct? All right, so we know it now. It's got a respiratory center that controls how deeply and how rapidly you breathe. And we'll talk about that when we get to the respiratory system. It's based on your blood CO2 levels. We know the cardiac center and vasomotor center because we talked about in chapter 1, regulation of blood pressure, that quick fix by the medulla. So to recap something I covered before, the reticular activating system, which is represented by this little purple line, okay, is in your brainstem, your pons, your midbrain, your medulla. That's your body's life support system. It is all about body functions that are very important to life. And so remember when I talked about in the cerebrum and sleep and how GABA quiets your brain to unimportant stimuli, something that you might hear some sounds, but you've associated in your life, there's no danger in those sounds, so you can fall asleep. GABA also inhibits your skeletal muscles, so you don't get up and walk around while you're in deep sleep because you could hurt yourself. But when you're in that vulnerable place of deep sleep, REM sleep, and you got that GABA inhibition, your body's autonomic nervous system, the brainstem, can rouse you if you sense something important, a stimulus that you've learned over your lifetime. I can't ignore this. And I left talking about it could be a fire alarm. It could be the alarm on your phone because that you've associated, I must get up when that goes off. It could be a baby crying, like Zoe, you're going to be awake a lot. For me, it could be an animal throwing up. All right, in my house, I've got 5 cats, and at one point in time, at least someone throws up once a night. So I will always wake up, especially if they're on the bed about to throw up. I will wake dead up from a sleep. That's the reticular activating system. Now, it's not always when you're unconscious in sleep. It could be you've zoned out. All right. Now, I know you don't zone out in my class because it's too interesting, right? But other classes where you just kind of zone out and you might not be asleep, but you've blocked everything out and you're kind of almost there. All right. It could be that, and something could rouse you. So here's my thoughts and how I think of the reticular activating system. I have 5 cats, love them, I love animals. But despite how much I love them and cater to them and coddle them, when they don't want to be bothered, they don't want to be bothered. Hey, Frankie girl, come on to mama, I love you. They don't care. But if I pop open a can of cat food, all of a sudden, either the sound of the can popping or the smell of the cat food, all of a sudden, they're wide awake and racing to the kitchen. That is a stimulus they've learned. I don't want to ignore that. That's goodies, okay? Another thing is more relevant to you guys. If you're in class and you zoned out and all of a sudden there's a stimulus and you jolted out of your zoning out, you realize you must respond to that. So this student, watch it, he was sleeping and the instructor started clapping, the students around started clapping. Like, oh yeah, I'm here, I'm awake. All right, that's your reticular activating system. All right, so that's what that does. Okay, so oops, let me move this out of the way a little bit so I can actually stay where it is. Oh, too far. So the reticular activating system has 3 stimulatory neurotransmitters that we know of, and 1 inhibitory one that we've talked about. So your reticular activating system is based on your lifetime experience and what importance you've attached to certain stimuli. Okay, so if it's unimportant, GABA allows your brain to quiet your skeletal muscles, and you can reach that deep sleep. All right, but if it's something important, and it all depends, that's very subjective, what's important to you as a stimulus, you can wake up. So it's in all of your brainstem and your thalamus and hypothalamus. It's everywhere. So 4 neurotransmitters, 3 are excitatory. So I've told you before that in your brain, oh, I don't like the red pen, ACH, acetylcholine, is always stimulatory. Low acetylcholine is associated with Alzheimer's because you're losing that stimulatory, those neurons that produce that acetylcholine And that's what's causing the loss of cognitive function in Alzheimer's, among other things. In your brain, norepinephrine, okay? Norepinephrine is what's in your brain. So I'll put CNS. In your PNS, the stimulatory neurotransmitter is epinephrine, but in your brain, it's norepinephrine. And that is going to stimulate your brain to be awake. A new one they just discovered is hypocretin. All right. And you don't have to write this down, but they did find out it was important when they were studying people who have narcolepsy. Anyone know what narcolepsy is? You're unable to stay awake, and more importantly, you fall asleep at inappropriate times, like you're driving the car. All right. These people who have bad narcolepsy can't get a driver's license because they could just. All right. And so they found that a loss of hypocretin as a stimulatory neurotransmitter was associated with people who had narcolepsy. And so that's interesting. Now, the one that promotes sleep, decreased awareness, is GABA. Okay, so we did cover that. We talked about the cerebrum and sleep. Talked about GABA a lot. All right. Okay, so you can click here, or I have it on the next slide. The effect of certain drugs on the reticular activating system. Some drugs are agonists, some are blockers. So what we've got here are amphetamines. Those are stimulants. Okay, they enhance dopamine because when you take amphetamines, you get that dopamine release. But that's not what we're talking about here. It increases the effectiveness of monoamine releasing neurons of the reticular activating system. Amphetamines are, I'll just say RAS agonists. Okay, it's a stimulant, makes your brain go crazy. Benadryl, I've been having bad allergies. I don't know about you, but I've been living on Benadryl. I take it at night because it knocks me on my butt. Because Benadryl, the antihistamine, Benadryl right here is antagonistic to acetylcholine in the brain. Okay, and because of that, it can cause drowsiness. So some people aren't affected by Benadryl that way. I am. It's definitely a blocker to acetylcholine in my brain, and I'll be asleep within an hour. Okay, so I'm sticking with the reticular activating system. So I'm going to skip this right here, but there's a lot on this. They're talking about GABA as well. Valium, which is muscle relaxant, benzodiazepine, we've talked about it before. Barbiturates that are like general anesthetics, the ones that knock you out for surgery, they work because they basically stimulate GABA. Alcohol does, like, enhance GABA. All right. So increased ability of GABA to inhibit the reticular activating system. So let's just put it real simple. Valium is an agonist to GABA, and that means it inhibits the reticular activating system. Okay, so that's how that ties in. Valium obviously relaxes your muscles by GABA, but since GABA also causes your brain to relax, it stops the reticular activating system from doing its thing. There's a thing when people are on certain drugs, they might not wake up when they hear or smell or whatever an important stimulus because they're under the effect of a narcotic or a drug or something like that. So someone who's under a general anesthetic, okay, there could be a fire alarm going off. There could be whatever. You are not going to rouse from that. All right. These drugs inhibit this so that you can't wake up because they don't want you waking up on a surgery table. Sometimes that happens, but not often. All right. Okay. So that's reticular activating system. Okay. We're down to the cerebellum now. And there's a lot to know about it. I'm sure you learned a lot in anatomy. Does a lot of things, but since I've been talking a lot about motor control, the cerebellum is important in fine motor control. So are different nuclei in the cerebrum, but many different parts of the brain regulate motor control. So I have someone who's doing yoga because your cerebellum plays an important role on that fine motor control. It also stores learned motor patterns or muscle memory. Have you ever heard the term muscle memory? When I open up my phone, I have a pattern. I don't think about it, I just go. That is a learned muscle pattern, okay? When you get in your car, I have a stick shift that's on the steering wheel, okay? Some stick shifts are down in between the seats. And so when I get into a rental car and it's got a stick shift that is down between the seats, I get in the car and motor memory, I just go up here and oh, this is not my car, it's not there, oh, there it is. But you do things automatically, like once you learn how to ride a bike, skateboard, whatever, all right? Those are learned motor memories. You don't have to think about them, you can do them automatically. Those patterns are stored in your cerebellum, so they're pretty important. So balance. People who have damage to the cerebellum will have what's called ataxia, uncoordinated muscle movements. And now if someone comes in and they show ataxia, it could be lots of things. Could be Parkinson's, could be Huntington's, could be basically a brain injury, okay? It could be problem with their cerebellum, which could be a brain injury, or you could be born with it, all right? And they will need physical therapy to help navigate as best they can in their world. So, and I know this from the veterinary world, because cerebellar ataxia, some cats are born with this. They're called wobbly cats, and they live a perfectly fine life, but they're like this, you know, and they try and eat their food from the cat food thing. Sometimes the owners have to help them. They're absolutely fine. They just have a hard time coordinating their movement. And people are born with this too. So it can be damaged too. You could have a brain injury, traumatic brain injury, and if part of the cerebellum is damaged, you might see cerebellar ataxia in your patients, okay? So it produces ataxia, lack of coordination resulting from errors in speed, force, direction of movement. Movement in speech too, because that's controlled by muscles. Person with damage to the cerebellum may reach and miss an object and then attempt to compensate by moving the hand in the opposite direction. So intention tremors. And so I have a video for this. There's no sound to it, but here's a person who's just asked to touch his nose. And you'll see after the ad, skip ad. No, thank you. Okay, so he's simply asked to have his arm out here and then to reach his nose. And he kind of, that intention tremor is classic for cerebellar ataxia. All right, some patients can get better, but once the brain injuries happen, there's really no going back. You just work with a physical therapist to try and do the best you can. Okay, so that's what that looks like. Now, I have another video, cerebellar hypoplasia. Hypo means low, and plasia means growth. So if you take it together, it's the cerebellum is smaller than it should be. So this is something that you're born with. And this is what I'm talking about, the wobbly cats. Well, there's wobbly people too. And they're just born with a cerebellum that's smaller than it should be. And you can diagnose this just with a CT scan or an MRI scan, and you see that the cerebellum is smaller than it should be. And there's no other problems that they can detect. So I've got a video of a girl, and I won't show the whole thing, but if you want to watch it on your own, you can. But she's living with cerebellar hypoplasia. Okay. Oh. That might be as loud as I can get it to go, but. Oh, it's trying to go through here now? Yeah, it won't even go louder than that. But, you know, they work with her. They said, I watched the whole thing. They said over the course of a year of treatment with physical therapists and everything, that she was getting better. But obviously it impacts her ability to navigate in the world. She's absolutely fine. She's not lacking cognitively. She's fine. And everything else about her is fine. It's just, she's walking around like a little drunk, okay? Because the cerebellum is smaller than it should be. So you see how important that balance and coordination of your muscles is when the cerebellum is not as developed as it should be. So a patient like this, it's dangerous, right? They could probably get better, especially if they start young, because kids' brains are incredibly plastic, which means they can change as they grow. Diagnosed early, treatment early, therapy early can make better advances than someone who's older and went undiagnosed. So that's a little better. So that shows you the power of physical therapy, all right, and a child's developing brain. So you'll see it. It's common enough that you'll see it. Okay, but I want to give you an idea about that. It's something that you'll see in your careers probably. And then whenever I've seen animals with cerebellar hypoplasia, all right? If they're small animals like a cat or a small dog, it's fine, but if it's a big animal, not so easy because they can really hurt themselves and other people. Okay, we've covered a lot. From here, we're going to switch to definitely things you're going to see as nurses, some very common things. And we're going to go back to some basic brain anatomy so I can explain something that's very important. So your brain meninges, the membranes that cover the brain. And in anatomy lab, I know they're using a lot of models now. When I used to have sheep brains. You can actually dissect the dura mater from the arachnoid mater, and you could actually see that dura mater right there, the outermost meninge, it's right underneath the cranial bones right here. That meninge is so tough. You have to cut it. You can't tease it. You can't pull it apart. Like I could take a thumb forceps, grab the dura mater and lift the entire brain up. That's how strong that tissue is. So it's not going to give. It's very strong. So that's the outermost meninge. I'll just put outermost. This should be stuff you know already. Now, underneath the dura is the arachnoid mater. And notice it has a blood supply. So it's the middle with a blood supply. Now that's important. Because if someone has a traumatic brain injury, like blunt force, not like cracked skull or anything like that, if you have blunt force trauma to the skull, it could be enough that these small blood vessels could rupture and then start a bleed. We're going to talk about that. All right, hematomas on the brain. Then the innermost layer is the pia mater right there, and that innermost with glial cells known as astrocytes, which function in the brain's blood-brain barrier. So it's a very selective membrane. It's going to allow gases through, glucose, some other nutrients, things like that, but then nothing else. All right, so hard bone. In adults where the sutures have fused, that is now solid bone case around your brain. All right, so imagine this. You get blunt force trauma to the head. You can fall down and hit your head. It could be as easy as that. And if it was hard enough to disrupt one of these blood vessels, they'll start bleeding. Now, the dura mater is not going to give. It's a very tough connective tissue. It's not going to rupture. So when that pocket of blood called a hematoma starts expanding, fluids trapped in confined space have tremendous pressure. That's how hydraulics work and tractors and everything like that. It's fluid in confined spaces has tremendous pressure. Now, that pressure is going to press outward every direction. But if it presses up, the dura mater is not going to give, and the bony case is not going to give. It can't expand. All right. So the pressure goes to the path of least resistance, which is soft brain tissue, which is like a hard tofu-like substance. And that pressure and that pocket of blood gets bigger and bigger. You're pressing on that brain. Intracranial pressure will skyrocket, and the person could die. Not immediately, even. If it's a slow bleed, it could be days later. All right. So when someone falls and hits their head, especially if they lose consciousness, even for a short amount of time, they must come in, they must get scanned to make sure there's not a pocket of blood bleeding there. Because if it's a small bleed, not much immediately, but in a couple of days, they could die. Bob Saget, did you read about that guy in the news? He used to be this person on Full House, which I never watched. but he was a pretty famous person. Apparently that's how he died. He fell, hit his head, didn't think anything of it, went to sleep, died. That's a classic case of a bleed on the brain. Now, they're still waiting for all that to come out, but when people come in with a concussion, all right, like blunt force to the brain. I had one when I was a kid, all right. I was brushing my teeth and I had a little stool because I was small and I must have slipped and I hit my head on the sink, which was hard, and cried, but then I was fine. And then my mom said, you know, she'd put me to bed because it was the evening when I was doing this. And it's fortunate that at some point I woke up screaming. Because if I hadn't woke up screaming, I might not have been alive in the morning. But I woke up screaming. My mom doesn't know what's going on, races me to the hospital, gets a police escort. They get me there, and I had a concussion. I'd had a tiny bleed. It didn't progress. It went away on its own, and I was fine. Okay. My aunt fell recently. It was when we had some ice, and she fell on a concrete, and she hit her head, and she was out immediately. Ambulance came. I wasn't there, but she did have a subdural hematoma from falling and hitting her head. As nurses, a patient comes in with blunt force trauma to the brain. They could be talking. You're going to ask them questions. You're going to evaluate how aware they are. What week is it? What day of the week it is? You know, who's the president? What's the city you live in? And they could be answering and doing fine. And then all of a sudden, right in front of your eyes, they crash on you. Then you get them to a CT scan to make sure, see if they've got a bleed. If they got a bleed, they got to go to surgery ASAP. Because they could be fine 1 minute, a few hours later, a day later, all right, they could crash because of this blood vessel bleeding, hematoma, tremendous pressure, and it could kill them. So, brain blood supply. This is blood vessels in the arachnoid space. All right, and then you can't see it, but the PMA would be underneath that. Here is a plastinated brain where they've injected all the blood vessels with the latex, and then everything else is dissolved away. And you can see, just with all the blood vessels, you can see the shape of the brain. That's how much blood there is. Your brain consumes 15% of all your arterial blood, 50% of all your blood glucose, and a few minutes of loss of blood supply, which is what ischemia is. A very general word. Anything that loses blood supply, especially if it's a very metabolically active tissue like the brain, those cells are going to die very quickly. So a stroke is loss of blood supply to the brain. My friend died of a stroke. Okay. Time is of the essence. The longer it takes for someone to be diagnosed with a stroke, the longer it takes for treatment, and then you could have permanent damage or death. This person, he just had a stroke because he had a heart problem. He had a disease in his heart, and he was supposed to be on bed rest or chair rest or whatever. And people who sit still for a long period of time, when they get up and move around, they're prone to throwing a clot, and that's exactly what happened to him. He got up to go to the bathroom, and he must have thrown a clot, and he went right down, all right? And eventually the next day he died of it, you know, loss of blood supply to the brain. So that's damage to the brain from a stroke. Necrosis is death of tissue. And so that right there caused the death of whoever's brain that is. All right. So stroke, if someone is, see, I've seen a reporter, a video of a reporter who was given a report live on camera, and she started having a stroke. And some people noticed it and said she started slurring her words, and all of a sudden she started to have a droop on one side of her face. Happened that fast, and they said, "You're having a stroke," and they got her care immediately. So if anyone calls in and suspects that someone in their life is having a stroke, that's an emergency. And like an emergency, like we're going to send an EMS to you. Okay, but that can happen. All right, so looking at the time here, I will have something that's quite shocking because it's real surgical footage. Hopefully, so I'm going to let you know that. All right, so you're prepared. But it says acute cerebral. Let's move this. You gonna let me move this? Here we go. Acute cerebral bleeding, hemorrhage, hematoma. That's a blood pocket. All right. So what we've got here is if you're hit blunt force trauma to the head, you could get a bleed, and it could be subdural, it could be arachnoid, it could be any place in there. That's a danger. All right. So here's someone had intracerebral hemorrhage, probably from a tumor. It could have been a cancer. Who knows what it was? But that obviously that person didn't survive because, well, there's a section through their brain. But the danger of this is the fluid buildup causes pressure necrosis. And that's what can kill part of the brain. And if that's happening someplace that's like the brainstem, you're a goner. If they catch it early enough and it's in the cerebrum, they could possibly save you. All right. It took my aunt a full year to recover from her subdural hematoma. She had dizziness. She saw lights and all kinds of stuff. She couldn't drive. You know, she had to be real careful. So it took her a full year to come back from that. But anyway, this is a video, and I hope the sound is going to be good. But the sound doesn't even matter. It's just classical music. But what you're going to see is an elderly woman fell, got a subdural hematoma, and they show you the CT scan so the surgeons know exactly where it is, where to go in. And then they show the process of, you gotta get that blood out, and it's surgery, okay? So this is where, you know, hopefully you can handle this kind of stuff. It might take a second here. Here we go. Okay. Let's see if we have it. No ad. Yay. So they just got this music in the background. So 83-year-old, kind of old, fell. They have a coma scale for how bad it is. Her left pupil was dilated and fixed. That's definitely a brain trauma thing. CT scan, left acute subdural hematoma. So left side here, that's the hematoma. It's actually squishing the left hemisphere of her brain over. There's the lateral ventricles. They're completely past the midline. So that's pressing a lot. That's a huge hematoma. Okay. So here's another scan showing it from this view. Her eyes would be here. Okay. So they've already done some work. She's obviously under anesthesia. They remove the skin, and they've already used a bone saw to cut through the top of her skull. They had to make that big of a cut because it's that big of a hematoma. All right. So they lift it off, they put it back. A bone heals pretty quick. But what's interesting is you're going to see the duramater, and they can pick it up with forceps. They have to cut it, it's that strong. So they're lifting up the duramater because the hematoma is right underneath it. So this is an exact case where the blood vessels in the arachnoid mater were ruptured. So I got to move that meninge off, and there it is. That is the hematoma. It's a very big one. They irrigate to slide it off because they don't want to use a lot of tools to cause any damage, so they just kind of flush it off. All right. So that's just removing the hematoma. After this, they've got to find the bleed and stop it. All right. So they irrigate, and when I see, it's a gusher too, it's an artery. When I see, oh, there it is, it's there. Can you see it? Yep, right there. All right, that's a pretty darn good bleed. So they're going to cauterize it. They're going to watch it, see if it definitely is cauterized. And they will watch for a little bit in surgery to make sure they got it. And they will most definitely insert a shunt into this woman's brain. So if there's any additional fluids, they can relieve that. They'll leave sensors to monitor for intracranial pressure and make sure that's dropping. All right, 3-hour surgery. Holy crap, that's it? All right, no complications. She lost 200 cc's of blood. That's like nothing. All right, that's amazing. That's amazing. So I don't know what experiences you'll get as a nurse if you ever do rotation, surgical rotation, but you might see some really incredible things. But as a nurse, you've got to be on the lookout if someone comes in with blunt force trauma. They're not bleeding. They're not cut anywhere. They sound like they're fine. You got to watch them like a hawk because they can go from fine to crash like that. All right. And those are life-threatening. Okay. Any questions about that? Because that's a really important thing. You got to catch that. The patient, if they're not monitored, they should not be. It looks like you're fine, so we're just gonna. There, you can go. Pay your bill. You can go. No, this is the case where we're gonna have you hang out here for many hours, possibly overnight, just to watch you. And the patients be like, I feel fine, but if there's a bleed on the brain, you can change very quickly and it could be life-threatening. And that's why you need to stay and be observed. You have to make sure and do that, because that's a way you can save a life is when they crash, if they're at home, no one's going to save them. So how do you evaluate the brain without cutting into it? So all the brain imaging techniques, this is just a little reading assignment. Now, all you need to know is what I put in the box. I just put the other information, just kind of interesting stuff. But X-ray, if you want to look at bone, like if someone's got a fractured skull, X-rays are great. All right. X-rays are not good for soft tissue. When they look at soft tissue through an X-ray, they usually use a radio-opaque substance. So this is, they're looking at the colon, and they either drank a solution that comes up white on a radiograph, or they might have given an enema to view that, because normally soft tissue doesn't show up on an X-ray. Air spaces show up black, bone shows up white, and anything else that's intermediate in density shows up as gray. So good for broken bones. Perfect. Not very well. This depends if you have insurance. X-rays are the cheapest way to look at the brain, but you can't look at soft tissue. A CT scan. Sorry about this. I'll move it. Maybe down here. All right. That's what that was showing on that woman that had the subdural hematoma. And it was great for soft tissue. This is an intracerebral hemorrhage. Not a good one either. Okay. Multiple X-ray beams as opposed to an X-ray, which is a single focused X-ray beam. These are multiple beams sent through the body, and it goes in layers. So if it starts out here, it goes deeper for the next one, deeper for the next one. It's like sectioning through a tissue, but it's doing with X-ray beams. And then a computer puts together all those images into a really high quality image. And that is really good for soft tissue. So has anyone ever seen someone get a CT scan? My husband went, you did. Wasn't you, was it? Yeah. Okay. So it does look like this, a big machine, and they roll you in, and then it clicks, click, 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 click. Kind of scary. My husband was terrified. But he lost his hearing, and they were looking to see if he had a tumor or something like that. But anyway, moderate in expense, very common visual technique. Now, more expensive, but better accuracy, better resolution is the MRI. Let's see if this is going to go forward. So that has the best resolution, but it's the most expensive one. And it uses a powerful magnetic field to make pictures of tissue. People who have any kind of implants, pacemakers, stuff like that, or anything metal, let's say they had a broken bone someplace and they had a metal rod, like a titanium rod, they can't get an MRI, at least of that body part, because it's a magnetic field. Right? Can't wear any jewelry. So as a nurse, someone's going in for an MRI, no earrings, no jewelry, nothing. You have to make sure, check their patient history. Do you have any implants, metal rods and bone, anything like that? Because that is not for them if they have those things. Then PET scan. This one's very cool. So the person's wide awake. They inject them with a radioactive glucose tracer, and that glucose is going to go to the most metabolically active tissues in the body, and that will show up on the PET scan as reds and yellows and oranges like this. Here's a normal brain. Here we have mild cognitive impairment, more greens and blues. Here's someone with advanced Alzheimer's. Notice all the black and blue, and that's loss of those neurons. So they're not active, so they're not showing up bright on the PET scan. So if someone has a problem, you could look at their brain and say, this part of the brain should be very metabolically active, like when they're talking or doing an activity. And if it's not active when it should be, when they're doing that activity, you've now identified a problem, probably loss of neural tissue, right? And once it's gone, it's gone. But these are used in research. These are used in medicine all the time. Nurses don't run these. They have technicians to do it, but interpreting them is pretty important. And the last one, we have one of these in the lab, but we only have one. So it's not, I would love to do a lab on this. It'd be so cool, but they're expensive. We only have one. Plus the patient, the student has to have all these sensors with little bits of gel applied to their skull. And probably not a lot of you will want to do that in a lab. So, but an EEG, electroencephalogram, measures brain activity, much like an EKG measures electrical activity in your heart, but this is doing it in the brain. This is done in sleep labs and in hospitals and things like that. Do not memorize all this, okay? But let's say, for example, this, tracking the time here. These are the slowest waves of electrical activity in the brain called delta waves. And it's when you're sleepy or you're zoned out. So if someone's wide awake and you see this, that's not what you'd expect to see. That's abnormal brain activity. Likewise, if someone is experiencing these beta waves, which are more active, and they're in deep sleep, that's also abnormal. So the certain wave are expected with certain kinds of behaviors and activity, and you're looking for a mismatch. But anyway, and I don't have a cost on this because I don't know what it costs. All right. Okay. So we don't have much after this, but this. I keep coming back to this because it's so important. Concussion. Oh, they got a concussion. What the hell does concussion mean? The most common medical term for a concussion is a coup-contracoup brain injury. That's what it's called. And it's because if you get blunt force trauma to the head, like you get hit or you fall or anything like that, think about football players. They got a helmet on, right, to protect their head. But what happens if they take a hit to the head? All right. So when you're in a car and you're going, say, 30 miles an hour, all right, and all of a sudden you stop suddenly, like you hit a wall, you hit another car, your body and all the things in your body are still moving with inertia at 30 miles per hour. And when you stop, your brain inside your hard bony brain case does this until it runs out of that inertia. Every time it smacks bone like that back and forth, you can have brain trauma, you can get a hematoma, things like that. That's what a concussion is. That's what happened to me when as a kid, I fell and hit the sink. I hit hard enough and my little brain must have gone, right? And I had problems. So this is what you got to be on the lookout for. So I have a little GIF of what this is supposed to look like. You gonna do it? I probably already did it because I sat there too long. There we go. So see, every time that brain bounces back and forth within the hard bony skull, it smacks and that soft tissue can become injured. They say people who box, people who do, go online and Google concussions in football players and how bad it is. They can actually have brain damage over a long career that because they've had injury. Boxers, Muhammad Ali developed Parkinson's, and it could have been the Parkinson's or could have been all the blows to the head he took as a boxer that caused his problems. So the cranial bone, when the brain bounces against it, can cause damage and bleeding. So that's a coup-contracoup brain injury. That's a concussion. Those are the things you got to look out for because those are the patients that could crash on you like that. But that's what that's called. All right, we got only a little bit left to do, and I think we can get through it. On Wednesday, very important day, I'm going to spend a lot of time going over acetylcholine signaling, and that'll be good review for you for the exam on Friday. I'll also then go over epinephrine signaling, but that's not going to be on the exam. Spinal cord, all I have to say about this is the spinal cord is arranged according to the vertebral bones it passes through. So you have a cervical part of the spinal cord, and even though you only have 7, cervical vertebrae, you have 8 spinal regions. Thoracic matches to the number of thoracic bones. Lumbar, you have 1 through 5 because the sacrum, not the sacral, the sacral is S1 through S5 because the sacrum is actually 5 vertebral bones that are fused. And then some textbooks will include a coccygeal region, others won't. Now, the only thing I point out about this is if you have damage to the cervical part of the spinal cord, all right, this is injury at the C4, and then they've lost, now they didn't say lost motor control, what it does, plegia means movement. So they've lost motor control over everything below that region, all right? Then C6, got a little bit region here, but everything, T6. So you can predict if there's damage at these spinal cord regions. And I'm going to get to the point there. Your spinal cord is got a division of labor. The front part of the spinal cord, the ventral part, handles motor movement. The dorsal part handles sensory perception. And so depending on where the injury happened, and was it the ventral or the dorsal, if it's ventral damage, there's a motor deficit. If there's a dorsal damage, it could be, let's say this, L1, but it was the dorsal part of that L1 spinal cord. You could put a pin in their leg, they might not feel it at all. All right, they have no feeling. Okay, so, and I'll probably truncate this PowerPoint, it's fine, because I want to end it today and then move on. But I do want you to know this. There's a division of white matter and gray matter in your brain, in your spinal cord, and they're a little different. In your brain, the white matter is found on the outside, but in your spinal cord, the white matter is on the exterior. The white matter is white because it's myelinated neurons, and it's involved in the information going from point A to point B. It's all about getting information going. Gray matter are cortexes that receive information, make a decision to make a command or an effect. So in the brain, the gray matter is on the outside. So if this is the parietal lobe, the parietal cortex, a sensory cortex would be here. The insula is right here, so the gustatory cortex is here. This looks like it could be temporal lobe, so the auditory cortex is located here. Okay, and here's some of the deep basal nuclei that I covered before. White matter's on the inside, transferring information. In your spinal cord, it's the opposite. The gray matter is on the interior and the white matter is on the outside. And so I don't know if you got this in anatomy, probably not. It's okay. The ventral part of the spinal cord, so basically from this line through, the ventral is all about motor commands. The dorsal is all about sensory perception. So what's happening here, information is going out this way from the spinal cord. Here, information is going up the spinal cord. So when I started chapter 4, I talked about sensory information and motor information. Sensory stuff goes into the spinal cord up to the brain. Motor stuff comes down the brain, down the spinal cord, and out the ventral side. So that's the direction that stuff is moving in the spinal cord. The only reason I go over it is someone comes in, they've been in a car accident, it looks like they've had a spinal injury, they go to CT scan or MRI. You find what part of the spinal cord has been affected. You find if it's ventral side, they're going to have some motor problems. Dorsal side, they're going to have some sensory problems. That's the difference. And I may consider some of this on Friday. I'm not Friday, Wednesday. I'll make a decision about it. Okay. So this is another view of it with more information. Don't worry about all this. But we have a sensory lab next week where you're going to do a 2-point touch discrimination test where someone's going to use a paper clip and touch your fingertips versus your palm versus your arm. And the subject is going to try and determine where they touch by 1 point or 2 points. That's this sensory from the skin or other places goes into the dorsal part of the spinal cord. And this is probably going to go to the parietal lobe's sensory cortex. Now, if it's voluntary movement, the command comes from maybe your frontal lobe's motor cortex, maybe the cerebellum, maybe the caudate nucleus, all these different places I said could play a role in motor movement. Comes down the spinal cord, goes out the ventral part into a muscle cell or a gland. So all those nerves that you learned in anatomy, and this is where we're going to wrap it up today, just to wrap it up. Musculocutaneous, radial, femoral, obturator, all those, they sciatic. They contain both sensory information that's going to be heading up the spinal cord and motor information that's heading out to muscles and glands. Those nerves you learn, they're not just carrying motor commands, they're carrying sensory stuff too. They're just going in opposite directions. All right. So that sounds enough for today. I might cut some material and decide what I want to cover on Wednesday, but then I'm going to go to chapter 4, part 3, and I want to definitely spend time on acetylcholine signaling.